to ask about, which one for my colleague to create more discussion. The first, how can we organize a clinical practice to confront these three evils, and if they have to face, how can we dismiss?
طبعا السؤال طبعا وجيه. هي اعتقد تبدا من اللاب. Transplantation is becoming more organized. I didn't have a chance to ask how far are you here in terms of the lab. I know you have a strong plan. لكن هقول لك اللي احنا بنعمله بالنسبه للبوست transplant. We monitor them by doing donor-specific antibodies using Luminex. And if anybody has donor-specific antibodies by Luminex, we biopsy them. And then they have to be treated. That's where the message comes. I.e., how aggressive would you treat them and how you treat them. At least we know. So, we are three transplant physicians and we have argument, disagreements. But in general, if you have this A and perfectly normal graft, we give them IVIG and we increase the immunosuppression a little bit. If the graft showed dysfunction and there is no specific antibodies in the graft, so first stage, you do the test in the lab, just blood, and you show that there is DSA in the serum, but nothing in the graft. With biopsy, people have this in the serum. So you do the graft biopsy and there is no basically support. So most people give them IVIG and we follow it. If there is change in the creatinine, we biopsy them again. But if they have from the start DSA plus biopsy finding of C4D, irrespective of creatinine, then we treat them aggressively. And aggressively here, one of my colleagues uses rituximab. I don't. I basically carry on with that, not immunosuppression. There is some debate. There is a recent paper showing that if the stain is in the glomerulus, it's bad news. And I think those people, to my judgment, should be treated with rituximab. You may not win, but at least you do what you think is right, and at least you try. If you see in the peritubular pillars only, nothing in the glomerulus, they have shown that probably is less dangerous. The problem here is that we don't have long-term, like 15 years biopsy. We talk about 5 years follow-up. Some people believe DSA is bad news, should be treated from day one. I think it's a little bit too aggressive until we know, because we still have people who have DSA in the blood, and the graft is very. So I think you can, IVIG is basically, it's expensive, but nobody pays in Canada for care. So we use it. And I have patients who live like 2-3 years, and they're doing fine. I've had also some patients who graft went down, and those who have to use major immunosuppression. Thymoglobulin, sometimes we used to use it. But now it seems that rituximab is a way, if you see DSA, and if you see glomerular staining, particularly if there is change in the slope of the creatinine or GFR. So but my advice is that you should really expand in the Luminex technique. I don't know how far are you with it, but it has to be done basically pre-transplant and post-transplant.
Another important point, every now and then we are observing that there is a good correlation between the clinical lab and the histopathology of the graft. I mean, sometimes we have a creatinine increasing from 1 to 1.5. And then the patient is passing with urine output, and the histopathology is just borderline, it is severe. It is antibody-mediated rejection and C4D positive. We don't have donor-specific antibody positive significant in our plan here. It would be rather rising this issue. And on the other hand, we have creatinine rising, it is very aggressive, 3 milligram per deciliter, and then we are doing this biopsy and we can find borderline changes only. So you observe these two correlations.
Yes, absolutely. Creatinine is a bad one. Creatinine, like anything, we use it because it's easy to spell. And it's poor marker. There's lots of publications on that creatinine. And remember, the kidney has a capacity and has a reserve. So you could have a kidney that's already from an elderly person and doesn't have basically enough reserve. And a little bit of head, creatinine will jump out. And you have a young kidney, for example, and a lot of damage inside it, but because you're using the reserve. It's basically like myself running and one of the youth here running with me. So we are different. So the graph findings do not correlate with the biochemistry.
But this is not the case. We have here living donor, and the plasma is giving is giving.
Oh, Jazakallah khair, that's an excellent point. This is an excellent point. There is an old paper from Mexico, and we looked at kidney results before transplantation. And I think part of the problem is when you do the testing on those people, you don't know how good the kidney is. And that's why I think it's very important to do ISO-GFRs and using good method. But we used 3 points and we published extensively until we got a neuroradiologist and told me, no, 3 points no good. You have to use 5 and you have to collect urine. That's on the ISO scale. So what would you say about EGFRs and all that stuff? So I think that that's important. Plus, when you do creatinine on someone, you don't know how much protein he's eating, and so it's a rough method. So really, to be fair, we don't know how to measure the absolute kidney function in the body. If you want to really test it, look at diabetes. Early on. Internist will see that. You get the fair because someone's GFR is 180. This kidney has that capacity early on. So when you see someone with a creatinine of say 0.8, well maybe it's limited. So I think part of the problem is basically the quality of the graph. And I think what we're trying to do, organize, and I know they're doing this elsewhere, we published a paper on we should have donor registry. I think the donors should not only be examined thoroughly and independently, but I think fair assessment of kidney function with a split GFR and making sure that you have a good method, I think is mandatory. That needs to be said. But to say that someone 30 years old means that his kidney is perfect, not necessary. So yes, there is a correlation, and age is a marker, but it's not the only one.
اولا شكرا جزيلا على المحاضره الجميله وجاست one question. The first question, what do you mean by autoimmunity? Is autoimmunity to the gut itself?
Autoimmunity is basically making an antibody.
To the antigen of the gut?
Autoimmunity means against something you have.
Yes.
Allo is something is not yours.
Yes.
So autoimmunity is that you're making antibodies against the allograft. Because the graft is not yours.
Yes.
But auto is an antigen that you naturally have in your kidney. Yes. But because the kidney is ruined, it's attacking the other kidney. But it's a common share between your body and the other person.
And the second question is, as far as I understood, the two levels of these are related to the ESA.
Sorry?
Two levels of the three are related to ESA, that a new development of the donor-specific antibodies in the recipient after transplantation. So, what do you think is the cutoff at which we should treat these donor-specific antibodies after transplantation? Is it absolute or certain cutoff?
Cutoff of what?
Of donor-specific antibodies. Should we treat every case of donor-specific antibodies?
Post-transplant?
Post-transplant.
Using which method?
Luminex.
Luminex single beads, we treat them all. NFI, basically, that we respect is about the 400, which is our negative control. Some other centers found that some people say 1,000, some say 800. I didn't show you because of time, obviously. There was a study, we were part of it, and the United States and Canada, and looking at basically actually accredited centers. and you see the difference between the MFI of the centers. Amazing. So I cannot convince you that you should follow the 450 or the 4 or 300. It has to be done locally using your negative controls.
Yes.
But I'm sharing this to show it remains a basically qualitative, not quantitative test.
Qualitative.
It is still.
Just comparison would be...
No. I'll come to this. The point is, there will be some difference in the MFI. So nobody can tell you mathematically 455. Nobody can say 550. It's used. But in general, if you look at the centers, I think there were about 30 centers. We found that at 450 is the cutoff, the MFI. Anything before this, it could be false positive. So and then what we do, we repeat it in say 2 weeks.
In your practice?
That's what we do. We repeat it in 2 weeks.
2 weeks.
Yeah. But if it's higher than this, we biopsy it. And if you have it then we treat it like this. But if they have it in the serum only, we tend to give them IVIG, and I tell you, it's very expensive, but it works, I think.
Allow me, I have a complementary question to the question. So this is especially for transplantation. I am doing next technology to assess the presence of antibody, whether the donor is specific or not, and I evaluate the immune fluorescence intensity. So what after transplantation? If we want to succeed in the management of these levels, how much frequency is this?
There is no standard guidelines that can recommend. أنا بنتكلم على recommendation دلوقتي B2, C. You do it at 3 months because there's a time, and then a year, and possibly twice a year. That probably would be reasonable. Anybody who comes with graft dysfunction, even the coordinator comes about it immediately because they know graft dysfunction, ultrasound, BK, DSA, and drug levels.
You follow this guideline in your practice.
The coordinators will order it at the level.
So if there's no rise of creatinine, you do DSA?
Oh, creatinine, except if there's someone comes with acute diarrhea, obvious and so on. But any rise in creatinine, we take it seriously. I want especially to the young generation. I cannot stress the importance that creatinine change in transplant is a late phenomenon. If you wait until you develop creatinine, it's really too late. So really you have to be aggressive and be young. Very, very important.
So just an increase in the creatinine of, say,
we say 15%.
4.1
percentage. We say 8%. Yeah, but some people say 20.
20%.
Okay, and some say 10.
10.
Some will say that.
Enjoyed very much this very nice lecture. And just wonder about the use of plasma exchange instead of IVIG in subclinical cases of acute rejection. Does it help? This is one question we need just from you. And the second is related to talking about the specimen for removal of the blocking antibodies. If we still just know that there is some sort of antibodies, remember that this occurred before. Does it help with this situation? Removal by immune absorption or something?
The new level will require a lot of intensive plasmapheresis, if that's what you're hearing too. So really, it will take a long, long time. And remember, most of these people are off dialysis. They hate to go back to dialysis because that's basically dialysis access, or if they use it, I'm failing again or something. So because of the low level, it does not mean that it doesn't work, but I think it would be too redundant. Sometimes we should actually even cite again, just 5 grams. So it's easier than basically the IVIG, for example. So with work, it would work, but because of the low level, then it will take a long, long time, so we do not do it for that reason. Acute injury is different. Acute injury is a must use. i.e. acute antibody-mediated rejection. That's obvious. This doesn't trace immediately. Yes, for the acute ones. And then removing everything. Of course, whenever you remove, you cannot beat the body. سبحانه وتعالى الخلق. لكن على الأقل عليك بتاخد الشياطين وشوية كويسين معاهم عشان أمور تمشي.
Professor Sharp, thank you for your elegant presentation, and I think most of the attendants are agreeing with the use of the Luminex technology in preparation of the coverage prior to transplant. But regarding the post-transplant Luminex examination, it's some sort of diagnosis, some subclinical rejection or subclinical immunactivity against the graft. This was suggested maybe a decade before by the protocol biopsy, as they showed in the lecture, but it does not gain popularity because we don't have a strong evidence-based medicine supporting that diagnosis of subclinical rejection by protocol biopsy have an impact on the long-term graft survival. So I talked now about a simpler way or less invasive way of diagnosis of subclinical rejection. But still the question, you have an evidence that diagnosis of this subclinical rejection will have an impact on long-term graft survival?
جزاك الله خير. يعني احنا published a paper على فكره showed that the protocol biopsy is not good. we believe the opposite. We have to appreciate, يعني تخيل ان just consider it's your son who has a kidney transplant. What would you like first? To have a simple blood test, and if it is positive as a screening test, you go for the biopsy or you just go for the protocol biopsy? Sure. Number one. Number two, I'm sure parents of those kids will come to you and they may say, I want to decrease the medication, the prednisone is too big. But if this person has a lot of DSA or has some DSA, you will not decrease immunosuppression. So it's very important as a guidance test to the immune system. And I think this is one of the points that I have another presentation, that maybe we should have markers for inflammation and autoimmunity that should be done as a routine. And I think there is, at least to my knowledge, at least 4 papers showing clearly there is autoantibodies in graft. Notice only, I forgot to mention something interesting. If you see recurrence of disease, particularly genes that are characterized by autoimmunity, you have to look for DSA at the same time. Now this is the recommendation, because they go hand in hand. So the point here is that it's a good screening test, that if you find it, you know that this system needs to be hit hard. So you should not decrease immunosuppression, you'd like to look at the graft more. So I think it's a guidance test, more than anything. But would treatment make a difference? Absolutely, that has been shown. If you treat it, at least by not decreasing the immunosuppression. The balance is all the time between decay, that's what we think. Infection, one hand, if you keep using the heavy immunosuppression, or this. You need something to guide you. So we do screen for decay all the time. So we have to, basically, we look at the data. What's the decay of the person? If the decay is negative, and the DSA is positive, you tend to have more courage to be aggressive with immunosuppression. And as I say, we use the cytokine quite liberally in this case. So will it make a difference? It will. Would I recommend it? I would. But if you don't have access...
Thank you for your comments, but I think, I believe that I have a similar problem in neurology, while urologists have been using the DSA for diagnosing cancer prostate for decades. In the last few years, we have votes that we are over-diagnosing our patients, and we are providing them sometimes unnecessary surgery and giving them harm rather than giving them benefit. So unless we have evidence-based medicine, I mean on my side, on diagnosis of DSA versus non-diagnosed DSA, and follow this patient in a multi-center institution for 10 years or something, to have a proof that diagnosis of DSA will have a real impact on patient graft and patient survival. This might be of a question till we have this answer, because adding immunosuppression, as you of course know, is not the job practice.
DSA causes graft failure. That has been proved. That's not, with due respect, that's not a controversy. The question how aggressively can you treat it?
That's my question.
And I agree with that, but you definitely can affect the course by not decreasing the immunosuppression of these people. You have the IVIG, and even sharing with you that some people go as far as giving rituximab to people with DSA without graft evidence of injury, just to show you the move. In my judgment, in a lecture like this, it's more to raise awareness, more to speak about controversies than very firm answers for specific things. That's what people thinking. That's why I have this get-go. So we really have to think of ourselves. It's a problem, and I tell you, in transplantation, this is a field now. How can we hammer this DSA? How can we hammer autoimmunity there? And how can we treat? If you look at the lung transplant people, they think it's also contribute to graft failure more than the others. So what does it mean? It means that the graft being hit from different angles.
Thank you, Professor Shokrat. It's really an honor and a pleasure to listen to your thoughts. My question is about cross-match before transplantation. If we have a patient with negative pan-reactive antibody and by Illuminex, and CDC cross-match is negative, what will be the impact of doing Illuminex cross-match for that patient on the decision of transplant?
You said already the Illuminex is negative to the CDC?
Yeah, but I mean it's a pan-reactive antibody. I mean, because we have...
Oh, I see. No, the ballot is on the screen. It has to be done by single beats.
But I mean, if...
My apologies if I didn't make myself clear. When you do Illuminex, you screen first, so you know which bead you are going to use. After the screening, you do the single antigen bead. The single bead antigen. It has to be done. Okay? It has to be done. The least you do, if you don't have that access, is the flow. Okay, the stronger or the antiglobulin. I know some centers still in the guidelines you can do that, but my preference would be for a flow because it's more sensitive than the CDC. Okay, but I'm sharing with you what we do. So what we do is that we screen with Illuminex. We do single bead antigen to identify those potential targets. And if they are present on the basically donor cells in living late transplant in our center, we do not transplant them if the CDC and Promax and the flow basically cycle are both negative. So we expected that far.
Okay, but I mean, is there any recommendation about that in the international recommendation? I mean, is that an international recommendation or just a practicing?
No. The international recommendation would be under peripheral, but it's not unethical not to do it. I.e., if you are a practicing physician, it would be acceptable in a court that you do the long-acting CDC or the antiglobulin CDC or the flow. These are acceptable. If you want the Cadillac paper, Cadillac treatment, you do the antigen, basically single antigen. So it's not the recommendation for the routine clinical things, but it's under peripheral if you have access to it.
Yeah, but I mean, when not this overestimate, and handle transplantation, will not this affect the rate of,
Jazakallah khair. With every increase in sensitivity, there will be some losers. But there are a lot of winners. You're right. And that's all the time, I think, the gentleman just was sitting here. This is exactly where you put your limits. And that's the value of the MFI, as we talked about. Where would you sit? That's something I showed you with the different MFI talks about this. So their threshold there was 450. Anything less than this did not make a difference, 5 years survival. So that's something you may adopt locally here. But if it is my son's kidney, that's what I'd like to do. Okay? And since rich country, they can do. I don't know, I'm not talking about Mansoura or anything different, but the guidelines is that you do not have to do. But living kidneys, you'd like to do your best to avoid it, especially if you have two donors. Two brothers,
Yeah.
and you do, and one has a living kidney. So that's what we do. And by the way, we have the living relative registry, which we swap kidneys. And it is in the bylaws of the living relative registry, LBPA, at Canada, that those who are single antigen B positive, we do not transplant them. So we switch them. So we respect it in Canada as a country.
Okay, and just another question, just to be sure about the cutoff of panel access for
I'm talking about the MFI of the single beat antigen.
Okay.
The other one is basically would be just yes or no based on the negative control. It usually comes at the same range, but that's not what we're interested in. Because there are lots of antigens. So you could have less antigen on the beads, giving you a false level. So you got to do single bead antigen. So you have it very pure antigen. It's like doing a flow, but using Luminex give you a picogram from basically nanogram. So it's quite sensitive. But you're right. With the sensitivity, you will lose the chance to transplant some people that probably don't have that we are humans.
Continuation to Dr. Ahmed's question. Since introduction of Luminex here, we have a limitation to the preparation list. What we are facing now that we have negative cross-match CDC and a percentage of class 1 or class 2 PRA, okay, which is donor non-specific, totally donor non-specific. We have we start to transplant those patients after refusing from the start. We start to increase 10% class 1, 15% class 2, then 20%. We reach it up to 30%. This is the idea. What's the recommendation regarding donor non-specific? Are these considered a fourth level or not a level at all? Or could we transplant them safely? And what's the cutoff point percentage then reactive antibodies with the negative, non-specific and negative CDC positive?
Last January 2013, in Transplantation, this excellent paper, I have a copy of it with you, talks about this. Nobody knows the right answer, but in general, there are some rules we can apply. Number one, if you have a Luminex technique using the single bead antigen, negative, even if the PRA is 90%, according to some groups, you will do as well as if you don't have any antibodies. However, it's debated by other groups to the extent, to show you how we have to humble ourselves, that some people believe if you are able to make antibodies, you speak the bad language. So sooner or later you are going to make the bad ones. So between those you have to judge. Number one, if someone has antibodies, now they will do well if you transplant them rather than leaving them on dialysis. And we know that the cutoff for balance is about 2 years. So if anybody transplant for more than 2 years, transplant is better for them. And those people have antibodies, so I think they should be transplanted. But that's where we are. So I personally, and that's what we personally do, that based on that rule, as long as you do not have donor specific, we don't care about the percentage of PRA. I will share more. We have now the sensitized registry in Canada. I think that's something we probably should think with other centers in Egypt, where we have people who are 98%, and they can get the single lucky draw, and we transplant them, and they will do well. So the PRA alone is non-informative in absence of DSA. Also, although there is a little bit of some debate about it, But in general, knowing that they probably immunologically high risk anyway, so I think for the benefit, I will go ahead and I don't care, as long as you're comfortable with the lab, I don't care about the theory.
So you don't respect the percentage.
No, the percent we used to do because we're ignorant. We don't know how to write.
And
We don't have to write.
you go the flows and which cross-matching this equation.
We do the flow as complementary
To CDC.
all the time. We don't use CDC anymore, really. I mean, sometimes when we get some fun results, we try to play with the system, but in general, we do flow cytometry all the time before the OR, and we do connectivity based just for complementary, because you could have false positive mistake, and that's the whole issue itself.
And what about your immune suppression in this equation?
In which one?
If you have the percentage high in RA with no DC,
If you trust the Winnipeg group, you think they are not immunologically high, and let me a little bit define this because we have some best interest. So they give them basically IL-2 receptor antibody in addition to this, which is our routine. Some others say no, we should give them time. Okay? But nobody will get a high PRA in absence of these A, rituximab, or else. But we will follow them after all. It's very interesting because the question is, do people who have high PRA immunologically more robust or just simple? It's like you saw the sun, so you blink. You're blinking because you have a problem with the eye or because the sun is strong. So we actually did, I think it's a good study, and we're writing it up. We looked at parameters of immunogenicity and inflammation. And we do not find a difference between people who have antibodies or not. It's only when you have the graph and you start to work this bad energy, when you see the immunogenicity goes high. So having antibodies, it's just natural. So it's a natural response. You have a blood transfusion or pregnancy or a graft, you make antibodies, there's nothing to kill anymore. So they are sad. So you don't care about them until you have their own graft for it. But there are papers to show, and the references I have them, showing that those people will later show. So we need to be more patient with them, but definitely our transplant. Our flow is a must. Flow is a must.
What about other markers? Other markers for inflammation, like OXB3. Have you experienced this?
We don't look at it. We think that the whole area is so fertile, and until good controlled studies by multiple centers will show the same results. The problem is you get one center, someone who is really strong, good technician, and find the results. You get to duplicate it. The reason we did the protocol study is beneficial or not. Actually, we were almost forced by the Winnipeg group who actually advocated routine surveillance biopsies. So they pushed us Canada-wide. We should do the study. We will prove to you that you're wrong. You should do protocol. Okay. So it was not cost lots of money. And to their dismay, it showed that they were wrong when they did mention it. Although they said, well, we don't care about elsewhere with it. So my point here is that the things have to be done routine. The non-HLA antibody, should you screen routinely for them? There's some preparation on this, and even if you do the MICA antibody, for example, some people say it's about 10% who occurs after transplant. But it's debatable which is causes injury or not. So should we screen or not? Maybe in a year or two we know. But I think the whole area is exploding now. Remember the B-cell, who cared about the T-cell? We used to worry about the T-cell. There's a recent excellent paper in AGT showing that actually in it's studies, but the transplant patients not making these A, you take the lymphocytes and activate them in vitro. They could reduce the and that shows what? It shows that there may be very minute amount this or that. Should you do this and you're thinking, people, how far would we go? You see, this is a beauty of science. The more you know, the more you need.
Actually, we have really a grand study about FOXP3, but it's still in progress. We have patients who do before biopsy in 3 months, screening before any antibody, any pathological changes, and after 1 year. All patients included in this study is low risk. It means that PRA is negative, that's 2. Cross-match minimally 105. And before biopsy will come, بنعملها 3 شهور. عن 3 شهور. عن 3 شهور حضرتك بنعمل بفور بايوبسي بنشوف الريزلت بتاعتها. لو بيرفكت ده بتبقى انكلودد كمان في حاجه ثانيه ان احنا بنعمل مينيمايزيشن. مينيمايزيشن للناس بمعنى ان احنا بنعمل رانdoمايزيشن بنقسمها على 2 arms. بس بتبقى بتكمل على سلوري FKMF and the other arm بتبقى shifted من tacrolimus لسيروليموس.
As a predictor, basically.
As a way 3, that's the unit 3.
I'm sorry, marker. Are you doing other marker with it at the same time?
Yes, we do CD3, and CD4, and CD125, and FOXP3.
Are you doing IL-17? Serum IL-17? You see, this is the problem is when you look at one marker, you have to look at the others because you could have the immunogenic markers higher, but you cannot explain. I have a very good case study here. A woman who had transplant doing very well, but she decided she's not going to take immunosuppressive drugs. So she will stop them for a month, and she cannot say, well, you know what, I didn't take them for the last month. And she's doing very well. So look, we told her, you tell us the truth, so we're going to study you. And we did a panel using Luminex about all the markers. And to our interest, all the markers of tolerance were high. We don't know why. But talking the same language, using the hope of all researchers to obviously use sensitive surrogate markers to help us tailor, and that's what we talk about the DSA, tailor the immunotherapy. If you can identify those who are more tumorigenic or more accommodated, then that would allow you to decrease immunosuppression and so on. So I think it's an excellent design, but I will recommend you to take both sides. Look at some immunogenic markers and basically immunoturogenic markers to make sure that, and you do serial related messages. Absolutely. The graft events are late.
نصحته الست تاخد ولا ما تاخدش؟
وكفهمت؟
الست تدرس الصدي بدي ادفايس حاطه كتير حتى لو هو خاص
You asked a very interesting question. Legally, I should ask you to take the medications. Scientifically, I don't want to. So I have to tell her what's legal. You have to. You see, this is the beauty. I remember actually that question الشباب اللي داخلين الدكتوراه. أنا سألت سؤال كان لطيف قوي في الميديسن زمان. واحد قال لي واحد عنده HIV، واحد حس إن أنا يمكن أجنبي ولا حاجة. قال له أنا عنده HIV، المفروض تعمل تيست بس تاخد مني الكونسنت. وقال لي طب مش عايز كونسنت. لكن واحد مع HIV يبقى شوف بقى السوسايتي. You cannot do it. So if the doctor is going to play a policeman and judge, that would be dangerous. So the guidelines that we have to stick with, even if we have ambitious scientific endeavors. So you do your best within the limitation of the system. I have to tell her, if you don't do, you'll lose a graft. She was transplanted in 2006. The creatinine by measure since 2008 when 20 hours divided by 88. يعني الوقت ده هي دلوقتي أكتر من 120 أو 30. ولا المغرب بتاع اسكندريه. حد موجود هنا بيجيب بابلش، وعندنا واحد اخ من الجيش قلت له عايز يبابلش، قلت له كل الحاله دي وعملت بتاع 20 مركز منهم الايس 18 23 هيموكاين and so on. Biopsy.
I think the issue of microbiology can be because again for this.
احنا عندنا الوهيس غالي في
الريجنز
مش في الهيستوريك الاول.
لا ولا طبعا هتبقى الصوره ولا بارك فيكم يعني. المهم بس الاستمرار.
الكيس الواحد يكلف كام دقيقة؟
1000 جنيه 1000 جنيه على
ما عادش
We need to shift for some issues in immune suppression. We need to know about the long-acting necrosis. Necrosis. What's your recommendation or observation? Because we recently introduced this drug and we have some notice, yes, about the big dose to achieve target level in comparison with the original twice daily tacrolimus. And we want to hear from you about this drug and if there is any advantage other than the compliance being once daily. So it's a matter of
It's a mix of all. We can study, I think we almost concluding it, we were part of it at the graph. It is a routine recommendation in Canada, not in the United States, which is interesting, that you can switch patients from you can, without anything. You don't need any consent, anything like this. All what it takes, 2 extra blood levels done. And you notice that the change would be about 1.1, 1.2 more. And there has been some race issues. Some people think that this would be young people, pregnant people. But the point is that probably the ratio would be, you need to increase the dose a little bit. The company pushed for it, let's be straight, pushed for it because the patent for the tacrolimus and the generic tacrolimus coming. So they wanted to do something. I am personally not convinced by basically the issue about once daily versus twice daily. Because twice daily, you have to take a subset of the method. So when you tell someone you have to pray 5 times a day, they pray 5 times. But if you still then pray once a day, they will forget. Ask me twice and you get حاجة. I'm not sure. Like in reality, I was proven wrong. And then sometimes بالذات في young kids, الأولاد البنات بيبقوا حذرين شوية. بتلاحظ إنهم بيمس دوز وبيمس التاني. فأنا I think if young transplant recipients will make an advance, you can make an advance by using the aspirin. We have a study as we speak looking at whether, as you know the curve, the AUC is more sharp for the 12 hours versus the 24 hours. We try to, it's already on the document in terms of the study registration and so on. We proposed, we don't know, we proposed that the more flat AUC could mean this toxicity because you're not hitting the cells directly this way. And we are doing basically inflammatory markers, cardiovascular markers and so on, before and after switch by 6 months. So the verdict in this is not out. But in terms of recommendation in general, we are so comfortable that we change it. There are patients who are stable with the tacrolimus. Say, no, don't touch me. I don't want anything. So those people will do well on the twice day. So really the issue in my judgment if you ask my personal opinion for Muslim, use the cheap. And I think the price are very good, but I think the difference, as I see, is the cheaper term. We are against generics. We are forced to accept generic. Like we think actually usage is important. We think in consumer it is different. So my short answer, in a nutshell, whenever cumulative is cheaper, go for it. But do not buy the idea hard that Ivogras is so superior because of this or that. But I think it's good as an addition for those selected patients that you think compliance is an issue.
Just one comment about Ivogras. We also don't have a problem with compliance because patients have to receive MMF at the evening. But we have some patients who receive the lowest possible twice daily dose of tacrolimus, and in spite of that, their level is high. So we're doing something like take it once daily or twice daily at one day and once daily on the other day. So was it beneficial?
You had the milligrams, okay? But that's good. Like it's the level is high. Very classical HIV patients on basically on treatment. They will need basically Ivogras once a week. So yes, you can do that. Those usually people have bad levels, I would assume that's what you have here. So yes, you do not have to use it once a day. You can use it basically once every 2 or 3 days. As I say, HIV 7 days.
Yeah.
So you can.
So I think its main use at our center here might be in those patients who receive the lowest dose of tacrolimus, and I think.
جزاك الله خير.
Okay.
مظبوط. كلامك صح. أكرمك الله.
I have a question from Dr. Khalid Omega. It was difficult to attend this meeting, and he sent me a lot of questions. But regarding immunosuppression, the whole question of cyclosporin. I know the use of cyclosporin nowadays is diminished in transplantation, but we use it in nephrotic and lupus, in some cases of lupus. His question is, what about C0 and C2? And how can you do if you find low C0 and high C2?
جزاك الله خير. We are actually entering a study as we speak, and we got the money for it from actually the university. We do the C2 for the last 20 years. And we published something about it, if I'm not mistaken. We first C2. I know some of the guidelines, but we respect it more than C0. And we know that people, particularly after 5 years, they have a C0 of say 30. Remember, the threshold for detection, we talk about 20. So barely there, and they use super C2. That's what we use.
So you follow the patient by C2?
We use C2. We see our patient every 2 months.
Yes.
When they come, we do C0 and C2. And when they go home, they do C2.
And what about the percentage of cyclosporin in patients?
Oh, and they know who we don't. Okay? But I know that other centers will do it, and personally, if I am in Egypt, and they tell me cyclosporin, the oral, is half the price of tacrolimus, I'll lose it. I think C2, and both companies, and we talk to them, both are scared to have the hit-to-hit C2 long-term study against that. All the studies were basically 6 months, and they showed basically was a non-inferiority study. There is no convincing evidence that tacrolimus is superior than C2, is superior than C0, in terms of at least the effects, for example.
This is what the girls was
No. Why do we use tacrolimus now? Because we think tacrolimus is less nephrotoxic, and long-term results probably, according to some, not all the studies, is a little bit superior. Sure, great. But you still have some particular patient that you need, for example, diabetics and so on, but leave this aside. I'm talking just one pregnant adult. there is no good prospective study comparing cyclosporin new or C2 monitoring versus tacrolimus. The most you get from one from Toronto was like 6 months, and the C2, within my judgment, wasn't the one that should be. So I believe that newborn monitoring by C2 is equally good compared to tacrolimus that we're using now. Because I think that tacrolimus is superior than C2.
Why we are following these C0 and C2 for the first 2 months and then C2 only after that? We are doing this to compare the level C0 and C2. If we can find this from the logic, we can proceed with C2.
No, but that will change by time. Even your time will change.
So why you are still doing C0 the first 2 months?
No, you do that. Oh, why you do it? Or why we do it? Why we do the C0? That's a good point. We don't know. The truth. We do C0, you see, when we actually start to use C2, we found that, and you took to the lab, they will tell you that you have to dilute the specimen. And sometimes a little bit of error will give you a false result, high or low. So we use a C0 just to make sure. Okay? Make sure. But in reality, you do not have to. The other reason that we use it, because our lab is like robots. So if you change anything, the whole system will go basically. You must. So do C0 and do look at it better than ignore them, you forget the tacrolimus. Because we have everything pre-ready. So calcineurin inhibitor C0. So if you tell them, do it for tacrolimus, but not for cyclosporin, you will confuse them. So just do it. So it's really unnecessary scientifically, but for those two soft reasons, we get to just keep the system running.
And what's the target? What's the target for C2?
The C2 early after transplantation, so usually we go for the 16 to 1800. Okay, early on for the first 2 weeks. Then we'll go by 200 every 2 weeks. Okay?
5 years ago, we tried to apply the C2 policy, but we were confronted with a high serum creatinine, 13.4, when we tried to adjust the dose according to the C2. So we did some comparison in about 50 patients that we did the C0 and C2 at the same time, and when we returned back to the levels according to the dose according to the C0, the creatinine comes down again. So we were confronted with some nephrotoxicity with the C2 in about 50% of these patients. This observation.
It could be the method itself, but the initial paper from Halifax showed that we follow the natural fact we tend to decrease cyclosporin more using C2 than C0. You're right, in the first 2 weeks there's a little bit of some debate. They think that 1800 is fine. Some people think that it's a little bit too hot. I personally think to go for 1600 and I'm happy, especially if you use IL-2 receptor and so on. Interestingly, it was found already by the Halifax group, and we're part of the study, that it is the cell set dosing that in the multivariate analysis, the early dosing is more important than the calcineurin inhibitor target level that we read. So it depends how you read it.
Thank you, Dr. Mahmoud. We talk about IVIG, rituximab in treatment of DSA. What's about something like bezekizumab, bortezumab, degolizumab, and it doesn't exchange?
All the meds, they are all case studies. So, and if you look at the rating of the bortezumab one, the recurrence were there. So, with due respect, either you're wasting your money or just using weapons that we don't know yet how to use them. So it's not yet in the guidelines, but it will be. Just give example. Someone third transplant, no hope of having recurrence of disease, and you have no hope. You can use it in your thoughts because you know that you are now getting into last basically stroke. That they are not routine, they're extremely expensive, and I personally, and we talked about this actually now in a meeting that was, I think, 2 months ago, that at least in Canada, I think the United States and the European will do the same thing, Australia, that we don't believe that it is yet close to be in a guideline if this doesn't work, what should we do? I think it is in the books, the studies are there. So I don't necessarily believe that they hit the target.
Thank you for the short lecture. I have a few questions. First, what about using the RNA markers depending on messenger RNA and predicting the early rejection before doing the biopsy?
It's a dream of every center. I know that actually the Winnipeg just actually got a patent for a urinary marker. So I think you have to remember the expenses of that. But I think the urine is an excellent look. It's like the ophthalmoscope. So nobody will debate this, but which one is really will be routinely available with the predictability, sensitivity to be used as routine. And remember, as a clinical tool, it has to be available. You're going to send someone to a lab just across the street, please do this. So the technique itself and the difficulty of doing it are sort of hindrance, but do I see this as a future? Absolutely. So I am sure that will be the future for Rahman.
There is a very nice review last year about the use of biomarkers in the cellular rejection and tumor rejection. And I think after the big review, very big review, they discussed every markers for rejection, either urinary, serum, and so on. And the conclusion was for cellular rejection, nothing is perfect. Even you suggest or expected that this marker will solve the problem. The results were frustrating. The only sure biomarker is DSA, as you mentioned. DSA has its impressive effect on the outcome if we follow DSA properly. But all the markers for cellular rejection were not helpful.
There are two good papers, one from actually the admitted one that I think what he said is alluding to. There's another one in KR. I think it's still sort of preclinical. Those are investigated and so on. There's a lot of literature coming in this area. Whether they will be routinely acceptable and reproducible by single task, I think that will be the money. But yes, I think the urine is a lot to the kidney as ophthalmoscope as we believe.
Another question, is it a must that every borderline change in the kidney treated with IV steroid, pulse steroid?
Say again, sorry?
Every borderline change in the RC treated with intravenous pulse steroid or?
Well, it depends on the creatinine. So if the creatinine didn't change, I personally did not treat them. Okay, and I think they are going to change the borderline now, or they have changed it, I should say, actually. So I personally believe if there is no DSA, no change in the creatinine, just protocol biopsy, I just observe it. That has been already done, and there are studies that showed yes, and studies showed no. But why is that? Because the limitation already in the biopsy. And in this, all the time when you see studies of this, you find that you talk about the pathology part and the concordance between the pathologists. It's usually, and nothing against pathologists, it's the difficulty of the job. I think it's the interpretation, those borderline that have hidden other areas of more than borderline and simply was not in the biopsy material that did bad, and the other way around. But if you ask me scientifically, would that make a difference in absence of these eight? In my judgment, it does not.
I think it is so important to do immunofluorescence screening for this borderline, for CD3 and other
assuming, just to be precise, borderline. You know, when you sit with a pathologist, I don't know if you're a pathologist or not.
الباثولوجيست قاعده
Well, Dr. Romano will tell you, she will ask you, oh, tell me how the patient is doing. Oh, how is his creatinine? Well, come on, I'm giving you the case. They do a remarkable job. It's really the limitation of the kidney to give you the information. We can't blame the pathologist. In actual fact, I attended a beautiful lecture on glomerulonephritis. And you know the main message is that we have to learn from transplant pathologists. Because the advancement in transplant, basically biopsies, is so far ahead of the others. We read members no problem. We need more. Why someone will do better, why not? So they're doing a great job. Nothing to take from what they have done. But the kidney is simply limited to give you information. It's like a baby crying. He does not cry because of anger, doesn't see his mother, he's in pain. So the same thing. So what you see the kidney is limited. We need other markers.
We have this problem here in some cases. The creatinine is high, we do biopsy, diagnosis on the line, we give the patient steroids, and the response was not good. So, and this is a big problem. You go the line, you take this high creatinine.
Go biopsy?
Biopsies.
You see, in cases like this, what we find if you look deep, it's, you know, there are cases that showing, for example, you could have an area of hidden vasculitis. Very classical acute antibody rejection, clean biopsy, and an area for the lung changes. That's one thing. The other thing is that BK. And if you go deep a little bit, and you should stain. We stain everything from BK and we do urine and serum BK with all biopsies plus stain C40. Okay? So I think I will find difficult to assume that you do a biopsy, you have more than 12 glomeruli in the biopsy, you do all of the above, and you don't know what's happening except the kidney biology is bad. That's what they call the kidney senescence. Kidney abusa. So the kidney, sorry, you got it from someone whose kidney function is borderline.
What do you do in this situation?
It's too bad, not bad. You got a bad kidney, that's a great loss. You should have taken this kidney for transplant.
Would you raise the patient to suppression?
No, because it will cause more damage. This is kidney, that's what this kidney is going to give you. Did you split GFR by the way? Yeah. So what's your limit for the kidney to take in terms of GFR? Like, do you have one, like, how low would you go for GFR? Like, what's your example for GFR to accept the total GFR?
The chemical clearance and isotope clearance should be 100.
When that's above my isotope, and you take which kidney, because the kidney is split. I know, but the risk could be 30%.
No.
That's what I'm saying. So
the experience increase the number. It is accepted to be 10 millimeters.
So those should be really good kidneys, because we got not really.
But this is my question. We can find some correlation between the clinical and histopathology. Sometimes a very aggressive pathology with slightly reduced creatinine. Sometimes we have significant rise of creatinine.
My recommendation would be, number one, you sit with nuclear medicine people to make sure that the kidney is not wrong. I have to confess, we published like 6 papers on ISO stuff. And then the new guy comes, fresh and research and says, no, this will give you about an error of another 50%. So the method. Number two, if that's the case, you must have something unique about this population. And I will suggest to you, do a study about the kidney reserve. Go to kidney reserve. See what this reserve is. Because I don't know.
Actually, we depend on clinical evidence. And as no place us just to calculate the percentage of function which kidney.
But that's the point. Urinary clearance means nothing.
This was it. We don't use the proper technique in G3A or...
I don't need it. If you are telling me that we depend on the total GFR on urinary clearance, that would explain the problem. You look at, just Google our name, we have seen error, overestimation and underestimation 50%. You could have a good correlation. You could have a urinary clearance of 100 and it is only 50. This is a problem. This is a problem.
So you follow the acid clearance by DTP?
Absolutely. We don't collect 24 hours anymore. We do even microalbuminuria when they are fighting. We do
The selection of the donor, we use acid clearance?
Absolutely. We don't ask them for 24 hours.
DTP and you collect
We don't collect 24 hour urine anymore. And I think that will explain, this is the value of sitting together. It's not me. Many researchers will tell you that. Urine clearance, the aerobic clearance is worse. This is the same study, one of the youth can do it. If you do the IDNS calculated GFR, anything that's high, IDNS equation tend to underestimate. It doesn't overestimate, it's 1%. That the low GFR does the opposite. So go back to this table and estimate their IDNS GFR. If it is above basically 90, it means it's very good because it's underestimated. So this guy is good. And that's what I tell anybody who will come to see me as healthy. Do your IDNS. If it is above 90, you are perfect. And when we did predictive values and so on, 1% error is underestimated.
IDNS another equation rather than
fault, but they work the same thing.
Yeah.
So my recommendation, this is an excellent, in my judgment, recommendation to you. It's easy. You have that parameter. Just do the IDNS in those people. Because you need to prove what's this reality.
But still, this could not explain most of the
Well,
cases.
because if these people, if the IDNS is above 90, you will prove that the kidney function is perfect. But if it comes lower than this, you do basically CKD equation, for example. You get accurate. What I'm suggesting to you is that you took those kidneys without being sure that the GFR is I'm not saying it's bad. You do not depend on those for our
But for your patients, if you have rising creatinine levels, borderline injection,
we don't collect 24 hours
yes,
anymore.
must avoid for these patients.
With that, sometimes if we can do something we think it's a rejection, we treat them clinically. It's like any clinical matter.
Going back to the lecture, you have asked to read a very interesting paper regarding the use of antibiotic.
Yes, that's the proceeding. All the lung people are doing it. They use basically this Omax for, and it shows that actually the chronic lung injury is decreased. Yeah. It has both anti-inflammatory as well as antibiotic effect. This data about diabetes is, remember the proceeding, the reading is very high. This is fascinating, and from the time there are at least 4 or 5 papers in KI, very good basic. Those B cells in the graft, they are not sitting there idle. Remember, and I think Dr. Amana will attest to this, in any area where you don't see glomerulosis, basically fibrosis, see this fibrosis, we see this lymphocytes, you need nothing. We look at area where they have healthy to use, nothing at all. Any lymphocyte in this tissue is bad, and it's doing very sinister things. So we become clonal, and we are fully active, i.e., some of them against the allograft, alloimmune dependent, and some of them are autoimmune dependent. But they are really get stimulated by anything. And therefore, and I think even Dr. Rakesh will remember this when we talk about why people make antibodies. We know this long time ago, but we didn't prove it. That we think by this exposure, we know from the CMP, when you get CMP with antibodies, it's the inflammatory component that you produce, make you more immunogenic, you make antibodies, you make all those kind of things. So, yes, yeah, I think it's a fascinating idea. The disease that I want to basically the young generation to appreciate this, autoimmunity and alloimmunity are not just two different citizenship. It's like Canadian Egyptian kind of thing. Both correlate. The whole world is small. So autoimmunity interferes and activates autoimmunity, and the autoimmunity by the inflammation will potentiate alloimmunity. They are not just sitting. The human body is not going to sit there and muscle. أي حاجة تحصل في حتة check it out with our IT department.
By the way, again, Dr. Militi, if you have patients with lupus nephritis with positive autoantibodies, how can you manage these patients for transplantation?
Lupus without clinical activity, who has clinically burned lupus for 1 to 2 years, we tend to transplant them, even if their basically chemistry is still remains abnormal. We warn them that the chance of recurrence is higher than those who don't have, but we do not bias against them because you see some patients will have, it's like anti-vasculitis, the same thing. So it's usually when you make the decision, you feel a little of discomfort, but it is not an absolute contraindication. But we tend to depend heavily on our rheumatologist, and we tell them, please write, is this patient has active lupus clinically? Yes or no? Don't tell me this. So clinical report.
Just to remind my question, the patient is lupus, is kidney disease, and we will have all this much more.
Yeah. You have to remove the ulcers. Yeah. Of course you have to remove the ulcers. By DDT, because if you have ulcers usually will give you 100%. So you know from the start that we have ulcers. So we remove the ulcers and do basically the flow. And by the way, usually the ulcers are IgM. It could be IgG, but usually. So that doesn't interfere with the next or with the flow.
So if I remove the autoantibody, there will be this reaction?
We don't care about the ulcers. Those are fine. They are basically doing nothing. You do transplant someone with autoantibodies against the nephritis. It's not a problem.
Sometimes we are afraid that the arrow is hidden on the auto.
Then you remove it in the lab by DDT. Yeah, you remove it. You have to remove it.
And if you remove and the arrow cross-match is negative, you
proceed. Absolutely. Yes.
Do this clinical activity.
Clinical is important because the current rate will be very
Well,
high.
understand we will respect this clinical activity. I have just rash, mother rash, but otherwise it is okay. Can I?
You can, yes. But usually we, like, once you come with the diagnosis, we make sure that they are at least a year to be on the safe side. Okay? But the mother rash alone is not a contraindication.
So regardless of the serologic evidence of activity, C3, C4, and longest and
I know because some of them have congenital those
And how about fever? Because we have a case of lupus with the kind of fever on dialysis, and with some activities which is taking no suppression.
No, you don't. If you have fear that there is a clinically active lupus, it will be unethical to transplant this person because basically you're giving ammunition for actually, remember, like pregnancy, if you use a portion in people who have clinically active lupus, you can make a bad flare. So it's an absolute contraindication if they have active disease. Active systemic disease. No risk of it.
Can you advocate Lumix for lupus follow-up and management?
I don't. Lumix has a lot of. Basically, it's like an ELISA. You can see ELISA by glow, basically. So you can do whatever. This is quite expensive because usually these and those are very expensive. So what we have in the lab, the thing with the ELISA and so on, they are good enough. So what you may advocate is that inflammatory markers, for example. But I don't see necessarily something for routine clinical activity. You know, for academic, then you can look at really subtle markers of activity. So other autoimmunities, activity conversions, for example, okay, inflammatory markers, chemokines, macrophage activation markers, and you can use it as protein or actually as RNA or DNA. So there are all of them available.
That would be a mix of different agents. We are going to introduce future, the near future, the hydrolysis that we can.
Yeah.
So what's the best combination for Certican, and can we shift safety from sirolimus to Certican? I mean, we have a lot of patients receiving sirolimus monotherapy. Is it safe after they have received the capital? Can we safely just one-to-one or to convert them to everolimus from sirolimus?
course, I think it's a good drug and it has been treated unfairly in Canada. We were part of a long study in 96, I remember. And somehow the company decided to wait the application for use in kidney transplant in Canada. It's used in Europe, I think that's why they are coming to you. Until the switch, it should be safe. It's a good drug. It's approved for the liver. It's good against fibrosis. So I don't think you have to, when you switch, I think it will be safe. The question, my judgment, is basically early injury. So are you going to use it for induction? So the recommendation is that the wound healing and so on is not the best. And you get funny reaction again with sirolimus, basically, brands in some patients. So it's good to add, but I don't think it's good for induction. I would not go, I think I'll go for 3 months, particularly if you have protocol, against fibrosis and so on. But for induction, then some people even don't because it's anti-growth factor. So it will simply enhance the acute kidney injury that happens early and dependent on growth factors. So my personal recommendation is to do that. The second is there is funny interaction between it and cephalosporin to the extent that it's almost contraindicated. So you are bound to use basically adagrasib at 3 months, which would be excellent combination, which we use a lot in terms of the sirolimus, subset, and so on. So that would be, in my judgment, you try to do. But avoid cephalosporin because it's intracellular level that hurt the kidney, even if the liver is not fine.
But for both transplants, we can shift and switch them safely.
Transplants who are on yes. Oh yes. It's a wonderful drug and I'm disappointed, although we have patients that could be used of it. But they basically withdraw the request for the kidney, although it's a food for the heart and the lung.
Excuse me to make it clear. If I have a patient who's contained 2 milligram serum, how much is it?
It's one. It's just beyond.
My question based on the pharmacokinetics because
it's the IV.
Yes.
It's basically like the Adagrasib tacrolimus to me. And if you remember on the literature, what they did is that one company has sirolimus, everybody says, oh, we got a breakthrough molecule immediately. Oh, let's get it, but we need to make sure that's right. So we had, I think, a CH3 or something, whatever they said, the number 17, that is it. So there are
2 milligrams sirolimus shift to 1 milligram.
Yeah. And we have patients that, as we speak, actually doing very well. But we have patients that are more for people who want to switch patients with them, especially young people who need against the fibrosis and so on. Some of them will feel just trapped. And that's what I used to say, that it's a good drug, but when it really has side effects, it just cripples you. So you have to be quite familiar with the side effects, and they are not minimal. So I would not recommend just to use it, but if they are already in sirolimus, they are okay, they are safe, so you should go.
Is there any head drive with sirolimus? Head drive with sirolimus?
Just we have, we were confronted with more than one case of recent transplant patients who have repeated acute cellular rejection. During maybe the first 6 months after transplantation, they received 3 anti-rejection steroid courses and 1 ATG course, and we can at least we can exclude humoral rejection. C4B is negative, and biopsy comes like grade 1 or even like borderline cellular rejection. I know that problems are problems everywhere, but I mean, we'd like to share your experience because we feel that we gave our patients a lot of immune suppression. Every time creatinine comes to baseline, then comes up again with acute rejection again. So, I mean, just to share your experience about this case.
And that's within the first 6 months.
Yeah.
And the DSA is negative. So this nonsense is cell rejection, basically. T cell predominantly. And you give them what again?
I have for example one patient who received three anti-rejection courses.
And ATG?
And ATG also. And another patient who is 4 anti-rejection.
Three rejection episodes within 1.5 months. They are kept on strong good form of steroid and the corpus with the full drug level and full dose of microfilm.
And compliant.
And compliant.
Yeah, I mean, for that patient I'm talking about, his personality is obsessive. He is very compliant to medications by minutes. So,
Cellular rejection should be difficult to have, especially if you use EEG. Okay. So did you stain those biopsies for BK, by the way?
no, but I mean, what's in our hands, we do like the decoys.
Because when you talk about a typical case, there's a problem. To my humble opinion, cellular rejection should respond to basically EEG. And usually there will be vascular injury if it is basically like E3. So my question to you, was it a cellular infiltrate only, or there was evidence of T cell in the glomeruli? I need to know the severity.
I mean, according to that, is between borderline and great.
And the creatinine goes up?
Yeah, I mean, borderline is like 1.2 comes to 1.67, then after anti-rejection comes to 1.2, 1.3, then comes next time to 1.8, receives the second immunosuppression comes to 1.3, 1.4. The baseline increases a bit with every anti-rejection course. So last time, I mean, for that patient, we had the creatinine like 1.7, 1.8.
And the biopsies are consistently, as you said.
Same.
Yeah.
Same.
So my feeling in this case, I think I'll use cytogam or IVIG in this case. We used to see it in the heart.
Yeah, because I mean, Dr. Ashraf suggested to have to receive IVIG or rituximab, but I mean...
No, I won't use rituximab in absence of this aid. This is a B-cell agent.
Yeah.
So don't waste time. I'll tell you a couple of things you may consider. The IVIG or cytogam, but also we have done this actually in the heart. We used to give them because we had no choice. We used to give them actually twice weekly or long course of AGG, and we did it before. So we give a small dose, like once a week or so. It will take about a 3 month or 4 months of this small dose, and that will tide it. Maybe you just give one course and that was it, because if you give more courses, he will get cancer. So how much total cumulative time will you give? For AGG? Like full dose.
Yeah.
Right? So if this man is rejecting now and the creatinine is going out with this kind of biopsy, I'll give cytogam. Didn't work, I'll give them a little bit of final, okay? Maximum 25 milligrams. Oh yeah. Basically about 25, i.e. 0.2 per kg. Once a week, okay, for a cumulative of 1 milligram. When you do that, you can tie and you hope, because remember part of the final action is simply to help accommodation. So I think this person would fit on this. We used to do those with a lot of T-cell infiltrates in the glomerulus. And you get some time, this would be rare. Usually we see it in the heart. But that's how we handle it.
So, I mean, sorry about that, but I mean, you are talking about IVIG, yes?
That's right.
Yeah. So what is the rationale of giving IVIG?
It's just this is an excellent immunomodulator. Okay? So it will basically block some of the receptors against which the T is stimulated, and at the same time protect against infections. Okay? So it will be an excellent addition because that's what you're dealing with. If that doesn't work, I give him a second course of Thymol, by the way I mentioned to you. Once weekly for say 4 to 8 doses. Okay? Because it seems that this T cell needs more those would be rare cases, but they are existing, particularly in the heart and the lungs. And this protocol is available, so you can use it fine this way. I remember actually my boss, long time ago, I remember he treated someone with family this way 6 months, but he was gone. If he loses something, he will die. So it doesn't have to be the old way that it's daily for community, basically 14 days, much or even when the French did it, 14 days too much. No more than 10 days, 7 days. So that you can do this way to avoid all the heavy immunosuppression related side effects.
But I mean, doing antibodies before going to the second, no? We don't need to have antibodies for starting another course of time.
No, I'm assuming that he has a cancer protection now.
Yeah, but I mean, can I use the second course and without doing antibodies for the drug? I mean.
Antibodies against ATG? What do you mean antibodies against ATG?
I mean, usually when we use ATG for one course, we...
Oh, you mean the skin test?
No.
What test do you do? Oh, you're looking for the first one? Usually it will be negative. You can do it. We give you 3 courses, that's fine. You can do it. No, we do the skin test. Because usually we use 5 and we do the skin test. Okay? But you do it, these are routine stuff that you will do. The pharmacy will tell you how to do it because you did it before. So yes, but it will be negative because you cannot know that antibody against it when it's heavy immunosuppressive. You don't use antibodies. Well, we used to use it. We switched long time ago, but we used it a lot. And we rarely ever, if you see someone with antibodies against it. So yes, but the point is that can you use it 2 courses? Yes. Can you use it interrupted once weekly for extended period? Yes, you can do that. And if you actually, in this case, use some of the IVIG, in my judgment, that the best way how you can use this immune system to be more at least tolerogenic.
Just I have just another question about immune suppression. I mean, we usually use the combination of tacrolimus and amylopectin in our transplantations. Do you have any concern about using both drugs simultaneously? I know that this is rather pharmacology question, but I mean, is there any problem of taking both drugs simultaneously? Do you usually separate both drugs?
The initial recommendation was not, but after this it changed. They want to give it a profile. But realistically, I don't care. Because they do the blood levels in a way, and the difference is minute. And then we'll differentiate the level.
The difference between?
Between the levels, if you give it simultaneously, or you give it 4 hours, it's just to be headache for patients. You wait for 4 hours to take. You don't have to do that.
So in your practice, you give both?
Not only my practice, my pharmacist tell me it's over.
It's over.
It is over.
Yes. They just are concerned about...
They can take it قبل ما يركبوا العربية الحلوة بتاعت الصبح دي. هم جايين من الصبح.
يعني مش كده بس الأكل بس
لا سهل. ياخدوا الاثنين ويصبحوا مع بعض.
بس أقول يعني تاخد وقت موضوع الأكل
انت سمك انجل بس كانوا زمان يقولوا يصنوهم عشان حته اللبن كانت حاجه جديده
بالظبط
لكن ما اسمها قصه
Regarding plasmapheresis and recurrent antigens, how much? Because we have a patient with persistent necrosis syndrome. So, and we are accustomed nowadays to do plasmapheresis every 2 weeks.
Every 2 weeks? Yeah. انتوا طيبين انا بعملها twice a week.
لا في الأول عملنا twice a week يعني it's twice weekly.
It's a frustrating disease because usually it's young kids. And the future is really, and you use it as grab, you get sick of grab from their mother, their father, and you do the same thing. It's terrible.
عملنا المشروع phase given us
I have a patient since, actually I'm going to present this case to Aisha. She's been plasma free since 2001. And she's 60 grand. But they're creating stable. That's fine. And she asked me, am I doing well? I said, you don't know if you stop the plasmapheresis. You're creating, oh yes.
بس فوق segmental are refractory young kid, 15 years, you see everything, he talks about different things, and still he has normal renal function, and still he talks simple.
Has normal renal function? Yeah. Then you're okay. I think put this way, as long as you don't have malignant syndrome, big proteinuria thing, my kid, like this, my patient, I think she has about 4 to 6 grams. That's fine, because you cannot treat it. This is like this is a real level. So, but remember, if you don't get the immune suppression, you lose the skin quickly. So I think we are treating them, but partially successful. Because remember, the measurement, not only the proteinuria, but the change in GFR. So when winning on the GFR, I think, like this patient alone, her creatinine, I mean, pretty slowly, I should say, but creatinine is like 212. I think about 3 years ago, it's like 190. Over 3 years, having 6 grams, should have been on that side by now. So, my recommendation is you treat them aggressively, you hope for the rest, but we don't know what to do.
بتقول الاطفال كنت حضرت لهم محاضرتين 3 واتكلموا عن حاجه اسمها فيش رايت ومن سندروم وبيدير ترايت ودو ميديكال تريتمني اند في سيرجيكال تريتمني والفرق بين حاجتين 3 هنا عملوا. هل الحاله اللي الدكتور اشرف بيتكلم عنها دي حاجه من الحالات دي ولا؟
Don't people congenital early on during infancy or early childhood? You do the nephrectomy when proteinuria called malignant proteinuria. And malignant by definition, some people say 8 grams, some people, I believe 12 grams. For those that malignant proteinuria alone, they are in terrible shape. For those, we almost have no choice. Okay? So you do it for that particular reason. The recurrence of nephritic syndrome is a completely different issue. Okay? And some people start actually do not care, but some of them will. And there are markers of this. So that's a different issue because the problem is, okay, you do get it in nephrectomy, and they give them transplant, and they get it again at transplant, so what will you do?
أنا بعتقد بوفرت إن حضراتكم تعلموا أهل المريض إنه هي ماست بي تايب تو ذا دكتور فور لايف. يعني هو بياخد الكورتيزون وأول ما يبقى كويس يقوم يبطل الكورتيزون. يعني تقولوا إنك أنت محتاج تفضل مع الحكيم طول عمرك مشكلة طويلة لكن من غير شر ولازم تتابع مع الدكتور.
احنا non-compliant patients بنخلي السوشيال وركر تقعد معاهم ولو ما استجابوش بنبعتهم جوابات.
هم مش فاهمين انها لايف ستايل.
كان جامد جامد I understand. But I think you touched a very important issue, compliance. Compliance is among the terrible reasons for losing grafts, especially when they do well, and then they stop or they become lazy, and then they develop the clinical graft nephropathy. It's bad behavior. At least be fair, all of us will do that. When we get a disease,
شفنا عيانين زرعوين كويسين وهم قالوا اطفالنا علاج غير كويسين. يعني زمايلنا بيقولوا لهم ان ده لايف ستايل.
Is there any advantage for tafurnus over cyclosporin for management of that primary liver disease? But I have a patient actually following the progressing also. She's 19 years old and she was discovered to have liver syndrome liver change since she was I think 5 years or so. And since then she was being changed from all immunosuppressives that she all know like from steroids to cyclosporin to MMF to even Inducin, lots of Inducin, and nowadays she's in immunosuppressive cyclosporin, and she's in the nephritic range of proteinuria for 1.56 grams per 24 hours, and normal renal function was good actually for her in favor. And Joe switching, she didn't try that so far. she had presented to criminals from Chinese world.
Based on the proteinuria alone?
Yes.
I don't think there is any good data to show that that is the way. I think both will. Sometimes you have patients who respond to one and not the other. But I think she's heavily immunosuppressed already. And if they keep the function stable, I'm not aware of any data to show that if you don't respond to cephalosporin in cases like this, you will be better. What we know is that cephalosporin is probably more nephrotoxic, particularly in patients with nephrotic syndrome. So that would be the only soft reason why that you said creatinine is stable. So if the creatinine goes up, I switch to try to give it the benefit of CNI without the direct nephrotoxicity. But in terms of the agent itself, I'm not aware that it has more selectivity or better agonistic. I think both will be GM. Cephalosporin probably more studied because it's older. But I'm not aware of any that show that that will do better than this. The only catch is the direct nephrotoxicity.
Rituximab has zero role for this patient.
For what? Which one?
For this kind of infection, for who is responding to all kind of infection.
No, but which side? Like focal glomerulosclerosis or
Minimal change, basically.
minimal change like this? I'm sure this minimal change, you remember I'm an old guy. Minimal change means they have to respond. I don't believe that minimal change doesn't respond. It must. This patient must have some deep
You mean she needs
glomerulosclerosis.
a microscope?
Huh?
She needs a microscope.
Not necessarily, no. The biopsy may be superficial. You see, the problem with the minimal disease, I mean, there are good articles about the minimal disease, IgM, Toraman, Toraman, or focal glomerulosclerosis. They are like a family. Least sinister in minimal disease, oral IgM, oral focal glomerulosclerosis. And the biopsy superficial, you may not get the focal glomerulosclerosis. And some people believe if you don't respond, it's focal glomerulosclerosis. So this patient, according to this criteria, and that's what they believe, that's not a minimal disease. So she's a focal, and rituximab has been used in it, yes.
Because even minimal change, there's a nice paper last year, or earlier this year, about the use of rituximab in minimal change.
نشكر استاذنا الدكتور احمد شكر ونطمع دايما كده ان يكون لنا نصيب ان شاء الله في الرياضه مصر باذن الله. الجميع مدعو يعني نسعد بالغدا مع بعض.
الساعة 2 ان شاء الله في المحمدي اللي في زيت الوقت نادي الجمعة. في معجون الوصل واعكاس المحمدي والمركز كده مش كل النظام يعني ان شاء الله.
Thank you.